Very good evening, everyone, and we welcome you for today's session. I would like to request you, Chandramohan sir, to welcome our resource person for today.
Greetings, everyone. This is Dr. Chandramohan, musculoskeletal and sports physiotherapist and founder of Exercise Testing and Prescription Organization. I am so excited to welcome you to this webinar. The reason is we have 1,500 plus registered participants from 18 countries: Sri Lanka, Saudi Arabia, Cameroon, USA, Oman, Australia, Lebanon, Canada, Kuwait, Egypt, Rwanda, Philippines, Nigeria, Bangladesh, UAE, Malaysia, UK, and almost all the states of our nation, India. We are honored to have such a diverse group of participants, and this is a great opportunity for us to learn from each other and share our knowledge. And we have our resource person, Dr. Greeshma A Shenoy, who is an esteemed physiotherapy professional with degree in kinesiology with a specialization in clinical exercise physiology from Texas. She further enhanced her expertise by completing an MBA in hospital and health science management from BITS Pilani. Currently, serving as a full-time consultant in cardiac rehabilitation at Dr. LH Hiranandani Hospital in Powai, Mumbai. And Dr. Greeshma brings extensive experience and proficiency in managing cardiac patients who have undergone various surgeries and medical treatments. Her knowledge extends to supervising exercise prescriptions and promoting wellness for senior citizens. Driven by a passion for research, Dr. Greeshma actively engages in research activities and has presented her work at national and international conferences. Additionally, she plays an essential role in public health talks, raising awareness about heart disease and its risk factors, emphasizing the significance of exercise in preventing and managing cardiac conditions. As an active member of professional organizations like the Society of Cardiovascular and Pulmonary Rehabilitation and a founding member of the NGO Shirayu's Health and Research Foundation, she contributes significantly to promoting cardiovascular health. Her dedication to advancing the field of physiotherapy is further exemplified by her life membership in Indian Association of Physiotherapists, reflecting her commitment to excellence in her practice. We are honored to have Dr. Greeshma with us today, and her vast expertise is sure to enrich our understanding of physiotherapy and cardiac rehabilitation. I welcome Dr. Greeshma to kickstart the session. Please, ma'am.
Good evening, everyone. Thank you, Dr. Chandramohan, for that fantastic introduction. I missed giving you out one vital part of my impressive resume. I'm also a mother to a 4-year-old. I think that also carries its own weightage. So, yes. Cardiac rehab, coming to cardiac rehab, it's a niche field, and in India, it is being practiced in some centers. In Mumbai, at the top of my mind, there are 4 or 5 hospital-based centers which are doing OPD-based cardiac rehab, following it up or many months and years after the patient has undergone a heart-related intervention. My topic for today is heart failure. And because lately, especially after COVID, a lot of patients are having issues with heart failure, and because of many factors. And let us see in the presentation that I will be having now on how to deal with these patients and how to treat these patients.
Go for full screen, ma'am.
My slides visible clearly?
Yes, ma'am.
Okay. So in today's session, we will see what is heart failure, what are the various types of heart failure, how do you approach heart failure? Is it just a physician-led approach? Is it a multidisciplinary team approach? What is role of exercise in heart failure? Since most of the participants here are physiotherapists, we would love to know what is the role of exercise in heart failure. Exercise testing and prescription in heart failure with specific guidelines for those who have what is called as an LVAD device, or the patients who have undergone a heart transplant. Few case studies and tips for patients that you can share. Heart failure. This is the abnormality of the heart, the cardiac structure, the muscle or function, which causes failure of the heart to deliver oxygen at a rate commensurate with the requirement of the metabolizing tissues despite normal filling pressure. In simple words, just like the photograph I have shown in the slide, the heart is tired, it is exhausted, and it just cannot pump anymore blood supply to meet the tissue demands. So I have with me a very nice video and very detailed explanation about the basics of coronary anatomy, the heart anatomy, a bit about heart failure and the various treatment modalities available from Dr. Swarup Pal, who is a senior CVTS and heart transplant surgeon. Dr. Swarup has undergone his training from KM Hospital in Parel, and he is well experienced in performing adult and pediatric cardiac surgery. He has also learned and sharpened his skills by training under legendary cardiac surgeon Padma Shri Dr. M.R. Girinath and Dr. S. Vijay Shankar in Chennai at the Apollo Hospital. He has been a DNB teacher and consultant, and he was an integral part of their heart failure program, which includes transplant, ECMOs, VADs. He's experienced in successful minimally invasive surgeries and robotic cardiac surgery programs. Apart from the heart, he also operates on vascular surgeries like removing blockages from the carotid arteries, reconstructing the limb arteries, creating hemodialysis access in AV fistula in dialysis patient, and reconstruction, cancer, oncosurgeries, and repairs of abdominal aneurysm. Let us hear from this gem what is heart failure all about. I will be sharing a short video that he has so nicely consented and shared with all of us. This is audible, right?
No, ma'am.
Video
Duna ma'am,
not
can we
available,
kindly
ma'am.
help you?
Not audible?
Kindly, video not available, ma'am.
Okay, wait. I will do it again. Thanks.
I think it will be better to stop screen share and redo it.
I will do it again. Redo it again.
Yeah, ma'am. Video available. Kindly play.
Sound available? Sound available?
Today I have been given a very
Yeah, ma'am.
interesting
It is
and
available
intriguing
now.
topic. Hi, this is Dr. Swarup Pal here. I'm the Chief Deputy Surgeon at Dr. L.H. Hiranandani Hospital in Mumbai. Prior to this, I was a consultant with Apollo Hospitals, Chennai. So today I have been given a very interesting and intriguing topic called heart failure. This is a topic which is of great interest to us because it is a very significant problem. Throughout our life. Now the heart, it has four compartments or four chambers. There are two chambers which are up and there are two chambers which are below. During life, both the chambers do not contract simultaneously. First the upper chamber contracts, then the lower one does it. Which maintained which maintains. Apart from this, the blood flows in an orderly fashion thanks to this sequence which is maintained inside the heart. So all the blood throughout the body comes to the right side of the heart, the right upper chamber. From that it comes to the right lower chamber. Then it goes to the lungs. It gets oxygenated and it comes back onto the left side of the heart. The left side of the heart now pumps this blood throughout the body. Let me quickly show you a model. Here in this case, this is the upper chamber. This is the right side of the heart and this is the left side of the heart. This is the upper chamber from which the aorta rises from the left side, and this supplies the blood throughout the body. Now within the chambers, as you can see, these are some partitions. These are called valves. The valves are like doors which open and shut, and they also help in maintaining the flow of blood in one single direction. Now coming back to heart failure. Failure, well, we all have heard this term failure. I mean, as parents, we would have told our children that you are not doing this thing. To perform according to your own potential or inability to probably achieve the goal or the function that you were meant to. Similarly, in heart failure, the heart is not able to pump effectively, and thus the blood that is required to be supplied to different parts of the body isn't. Now, heart failure can result from a number of causes, but why is this such a big problem? Well, let us talk about numbers. The most important thing is there are 5 lakh people currently affected with heart failure. Well, 5 lakh is a huge number. What is more significant is this results in 3 lakh of deaths every year. Now that's a very big number. So if we have such a substantial population suffering from the disease, it is better that we take care, identify it early, and then see how we can treat it. So coming down to our talk today, the first thing that we understand is what causes heart failures. Now, there are different causes of heart failure, but the commonest is coronary artery disease. What is coronary artery disease and what are the coronaries? Well, the coronaries are the blood vessels that supply is going to get a heart attack. So, coronary artery disease resulting in heart attacks, these are the commonest causes of heart failure in the world.
Greeshma ma'am, I think the video is stopped. Ma'am, I suggest that we can share the video later. I request to start your session, please. Greeshma ma'am,
Sir, your voice is also
there?
stacking. Grishma ma'am, are you there? Kindly unmute.
Yeah.
Ma'am, we can share the video later on. I think that will be better. Kindly, can we continue with the session?
We'll do that.
Because the video was stacking and audio was also not clear for everyone.
Okay, sure, we'll do that. So let me get on with am I audible now?
Yes, ma'am.
Audible,
You're
visible,
audible.
yeah. Let me get on with my presentation.
Presentation is available. Kindly go for the full screen view, ma'am. Yeah, please continue.
So what are the causes of heart failure? Coming back to heart failure, what Dr. Swarup was mentioning, the most common cause is a heart attack. Okay. But what I have here is how do you remember these causes? There are many causes. Heart attack is a common one. So there is a very simple mnemonic you can use, which is heart may die. Okay. Just as it goes with heart failure. So H for hypertension, E for embolism, A for anemia, R for rheumatic heart disease, T for thyrotoxicosis, M for myocardial infarct, which is the most common cause, A for arrhythmia, There's nothing on Y. D for diet and lifestyle. I for infection. And E for endocarditis. So the most common causes of heart failure, as I mentioned, is a past heart attack or a myocardial infarction. A heart attack occurs when the artery that supplies blood to the heart muscle becomes blocked. The loss of oxygen and heart's muscle tissue. The damaged heart tissue does not contract well, and therefore this weakens the heart's ability to pump blood, leading failure. The second common cause are structural changes involving the nerves of the heart, which cause pressure or volume overload on the heart. So heart from diseases, infections, or it could be a defect which is present at birth. Valves don't open, they don't close completely with each heartbeat. The heart muscle has to more and harder to keep the blood moving. If the workload is great, heart failure is. The third important cause is a heart. Any damage to the heart muscle alpha present at birth, congenital heart problems. If the heart and its chambers and the valves are not formed correctly, healthy parts have to work harder to make up for it, just like normal heart valves. Whenever the parts of the heart have to work harder,
Screen is not visible, that PPT is not visible.
okay,
Kindly
let me share again. Again and out.
Ma'am, you kindly switch off your video so that you will have a very good signal strength.
That's better. I'll do that.
Yeah. But share the PPT.
Yeah. Is it visible?
Not it, ma'am.
Okay. Yeah, it's available now, right?
Yes, ma'am.
Yeah. So I wonder at what point I got logged out.
Yes, ma'am. From the last slide.
Okay. So the common cause heart failure, attack, valve changes, heart muscle disease, and congenital birth defects in which the heart chambers are not formed properly, or heart valves are not closing properly. All these factors would eventually lead to a increase in the load on the heart, has to work harder, and therefore leading to heart failure. There are some lesser common causes of heart failure, but these should not be should also be considered when you make a diagnosis.
I am sorry to inform you guys, network is very poor here due to heavy rainfall.
Greeshma ma'am, I will be sharing the screen for you.
Is my screen visible?
Tuna ma'am, am I audible to you?
Yes, sir, you are audible to me. Madam was also audible to me, but her voice is stacking.
Greeshma ma'am, I will be sharing the screen for you.
Sir, your audio also is poor here.
Yes, that would be fine, please. You can do that.
Yes, ma'am.
So we are on slide 6.
Yes, ma'am. You just say next slide, I will be changing. Is this slide?
Sir, kindly go for the 6th slide. You are on the first slide only. Slide is not moving. Slide is not moving, sir.
Now?
Stop screen share and redo it. Yeah.
It's
Common
moving now.
causes of H. Yeah.
Yeah, we are on this slide. So some of the lesser common
Yeah.
causes of heart failure, low red blood cell count, which is severe anemia. What happens in anemia is when there aren't enough red blood cells to carry oxygen, the heart tries to move the small number of cells at a faster heart rate. And therefore, it can become overtaxed or tired from the effort, leading to heart failure. The second one is hyperthyroidism or an overactive thyroid gland. This condition causes the blood to work at a faster pace, and therefore the heart can be overworked trying to keep it up. And an abnormal heart rhythm, arrhythmia or a dysrhythmia, as I have shown in the photograph, indicating a irregular heartbeat. When the heart beats too fast, too slow, or it is irregular, it may not be able to pump enough blood to meet all the body needs, and thus leading to heart failure. Next slide, please. Next slide, please.
Yeah, ma'am. I am changing it.
Okay.
I just think that it is taking time to little load the slide a little.
Yes, ma'am. Yeah.
So when the heart fails, what happens? Okay. So the body tries to incorporate compensatory mechanism. What happens in heart failure is a decreased cardiac output. So what would the heart do? It would increase the sympathetic nervous system activity, leading to increased heart rate and cardiac contraction, and thereby try to increase the cardiac output. It will activate the renin-angiotensin aldosterone system, which will cause increased sodium water reabsorption in the kidneys, increase the preload. The renin-angiotensin mechanism will increase the catecholamine release, thus increasing the heart rate and cardiac contraction, and therefore an increased cardiac output. So, in short, the heart will try to, the body will try to do what it can to increase the cardiac output, because at the end of the day, it has to meet the body demands, the muscle demands, it has to provide oxygenated blood to all parts of the body, and therefore the heart will try to compensate with all these mechanisms. Next slide. So how do you classify heart failure? We know we have diagnosed a patient with heart failure, but how do we know whether it is a patient requires immediate attention, immediate admission, patient requires medical therapy, patient needs to be given surgical options? But before we do all that, we need to know what stage of heart failure is the patient in. And the most important terminology which is used to describe heart failure is based on the measurement of the left ventricular ejection fraction. This terminology is important because of its prognostic importance. Lower the EF, the poorer the survival. So when it comes to the ejection fraction or the EF, we have three terminologies or three classifications, which is heart failure with reduced ejection fraction, which is called HFrEF, heart failure with mildly impaired ejection fraction, which is called HFmEF, and heart failure with preserved ejection fraction, which is called HFpEF. So R, M, and P. Reduced ejection fraction would be those patients in whom EF will be less than 40%. Mildly impaired ejection fraction patients would be those in which EF is 40 to 49%. And preserved ejection fraction or HFpEF would be those in which EF is near normal, more than 50%, and yet they are in the compensatory heart failure stage. The second category in which we can use terminology to use to describe heart failure is that it is related to the time course, which is the progression or which is related to the progression of heart failure. Patients who have had heart failure for some time are often said to have chronic heart failure. A treated patient with symptoms and signs which have remained generally unchanged for at least a month is said to be stable. If a chronic stable heart failure patient deteriorates suddenly, the patient is described as decompensated heart failure. And this happens suddenly, which is acutely, usually leading to hospital admission. And this is also an event of prognostic importance. So heart failure related to time course would be new onset heart failure, transient or chronic heart failure, and related to progression would be acute, stable, or worsening. Classification, we also can have classification related to the location of the heart failure, whether it is the left heart failure, right heart failure, or a combined heart failure. Pretty much in clinical practice, related to ejection fraction is something that we as physiotherapists can follow, because this is related to how you prescribe a exercise program for these patients. And all the guidelines that we follow, the American Heart Association guidelines, the ACSM guidelines for prescribing exercises in heart failure patients are consider the ejection fraction as a parameter when you prescribe an exercise. Next slide, please. Yes, so how do we treat heart failure? Heart failure being the complex disease that it is, it requires a multidisciplinary team approach. A multidisciplinary team or a MDT is considered the gold standard model for the delivery of heart failure care. Heart failure occurs not to just the patient, but when the patient is diagnosed, it is also the family and the caregivers who are drawn into the picture. Hence, for this purpose, this multidisciplinary team should have following aspects of care. One, it should have a core team, which will have a physician, cardiologist, cardiac surgeon, and a heart failure clinic coordinator. The extended team, because heart failure, when it progresses, the other organs of the body are also involves geriatric specialist, a pulmonologist, oncologist, nephrologist, vascular specialist, dietitian is a part of the core team, and the exercise specialist again is a part of core team. A mental health professional or a counselor is also required for these patients, not just for the patient, but also for providing family support and caregiver support. And at the center, when you keep the patient in the center, you can have a multidisciplinary heart failure clinic or multidisciplinary heart failure treatment for these patients. Okay, next slide. So symptoms and signs of heart failure. Typical symptoms that we see in heart failure is breathlessness, orthopnea, dyspnea, reduced exercise tolerance, fatigue, tiredness, increased time to recover after exercise. When you put a ECG monitor on these patients, depending on what is the cause of the heart failure, you can easily make out the ECG changes in these patients, and ankle swelling, because of which there is weight gain. Next slide. Yes. So these are the typical symptoms: shortness of breath, swelling of feet and legs, chronic lack of energy or feeling tired all the time, difficulty sleeping at night due to breathing problems, which is paroxysmal nocturnal dyspnea, swollen or tender abdomen with loss of appetite, cough with frothy sputum. Sometimes when you auscultate these patients, you will hear basal crepitations, increased urination at night, and sometimes confusion or impaired memory. Next slide. Exercise testing in heart failure patients. So now we have some idea of what heart failure is and what are the symptoms with which these patients would come to us. So let's say, for example, a chronic stable heart failure patient has come in your OPD, and as an exercise specialist, you would be prescribing an exercise, or you would be telling the patient what to do, what not to do. So before you do that, you need to evaluate the patient, for which exercise testing is important. So symptom limited exercise testing is safe in HFrEF patients. If you remember from my earlier slides, HFrEF is heart failure in reduced ejection fraction, which is less than 40%. Since exercise tolerance is reduced in these patients, the exercise test that is selected for these patients is one that begins with a low intensity and lower changes in the work rate. Typically, a modified Norton protocol is used in case you are using the treadmill test for these patients. Submaximal 6-minute walk test is also done. In case there are research studies that show that if the patient has achieved around 300 meters in the 6-minute walk test, it is a indicator of good prognosis. There are many studies, old studies, that point out to this average number of 300 meters in heart failure patients. Next slide. After testing, when you prescribe an exercise program for these patients, you will follow FIT principle, which is frequency, intensity, time, and type. Frequency of aerobic exercise for these patients is 3 to 5 days per week. You can do resistance training after 2 to 3 weeks of being in an aerobic program for 1 to 2 days of the week, which will be non-consecutive days. Intensity, typically you see 60 to 80% of the heart rate reserve. However, these patients will be on medicines that control your heart rate, that control your blood pressure. So it is a good practice to also use RP, that is your rate of pursued exertion, on a 6 to 20 scale while prescribing or increasing the exercise intensities patients. The ACSM guidelines recommend that you use an RP of 11 to 14. In clinical practice, you see that in these patients, 11 to 13 also is tiring for these patients. Most important aspect of an exercise plan for these patients is stretching. The stretch should be for 10 to 30 seconds hold with static stretching, 2 to 4 repetitions of each exercise. Reason being that with stretching, the patient also tends to relax a bit. There is the component of pacing involved in your exercise regimen in between when the person stops to stretch the muscles a bit, and thus pacing is very much required in heart failure because these patients are tired, these patients are fatigued. Hence, to uh, reduce the effects of tiredness and easy fatigability, you introduce pacing, you introduce deep breathing during the exercise program, and you give them exercise in bouts of 5 to 10 minutes, give a break, patient can stretch, patient can do deep breathing exercise, again perform 5 to 10 minutes and then give a break. This is called as pacing. Time progressively increase up to 30 minutes. If patient is comfortable, there are no ECG changes, patient is not symptomatic, oxygen saturation is maintained, you can very well increase up to 60 minutes. On an average, the goal of your exercise plan is to, one, improve the patient's quality of life, get him back to activity of daily living, and get him back to build his effort tolerance up to 40 to 60 minutes of aerobic exercise. Type of walking: large muscle body group exercises such as treadmill, free walking, stationary, recumbent cycling can all be done in these patients. Next slide, please. Special consideration. Since heart failure patients are considered high risk patients, we need to have certain special considerations in these patients. More recent research data has come up which shows that high intensity interval training can also be considered in these patients. And there is a fantastic data on this particular aspect. So typically, if you don't do high intensity training on a heart failure patient, but over the period of the last, I think the last 5 to 8 years, there is a lot of research coming out, in which people have done high intensity aerobic interval training in heart failure patient. But the patient criteria in those cases have to be fixed. It cannot be those, it has to be fixed. It has to have a cardiologist or a physician clearance before you engage the patient in this kind of program. And if you do so, then it is recommended that the heart rate reaching 90% of heart rate reserve. The heart rate reserve, as you all know, is calculated by subtracting the resting heart rate from the maximum heart rate. And maximum heart rate you would get from 220 minus the patient's age. So you would get the heart rate reserve, and 80-90% of heart rate reserve can be utilized to do high intensity aerobic interval training with adequate physician clearance prior to starting with the exercise regimen. In general, a debilitated patient comes to you, the duration and frequency of the effort should be always first increased before increasing the patient's exercise intensity. So aim should be to accumulate as much duration and then gradually introduce components of exercise intensity in these patients. And after the patients have adjusted to the exercise regimen for about 4 weeks, as I mentioned earlier, 3 to 4 weeks, then resistance training is initiated 2 to 3 days of the week on non-consecutive days. Next slide. Now, special considerations for patients with LVAD. What is an LVAD? And was very well covered in a video. I think Dr. Chandra Mohan will be sharing it with you all later. LVAD is typically a left ventricular assist device. In short, it is you can say it's an artificial heart. So patients with this device do not have a palpable pulse. And therefore, you cannot take the blood pressure measurement by using your sphygmomanometer, auscultating, or using an automatic cuff in these patients. In these patients, you have to measure the blood pressure by at least by using Doppler. Okay. This is just from an information perspective. In these patients, when you consider increasing the exercise intensity, the mean arterial pressure has to be considered, because you would not get a systolic and diastolic pressure in these patients. You are not measuring by the traditional method, right? So you use the mean arterial pressure. The formula for calculating is on the screen. And the safe range of this mean arterial pressure is 70 to 90 millimeters of mercury. Again, in these patients, early onset fatigue is very common. You can put yourself in the patient's shoes and see when you have had heart failure, end stage heart failure, you are on list for heart transplant, and before that you undergo the LVAD device. So the amount of weakness, the amount of fatigability in these patients is very high. So you have to go very slow in these patients and introduce pacing in all of them, which will include stretching, relaxation, a little bit of aerobic exercise, again stretching, relaxation, a little bit of aerobic exercises. Next slide, please. Special consideration for patients with cardiac transplantation. So after an LVAD, typically a surgeon would go ahead with cardiac transplantation if the patient fits the set criteria, etc. How do you test these patients? If a patient of heart transplant has come to you, how would you know at what level to start the exercise in these patients? Because heart transplant, as you know, is a major surgery. And it is not easy to plan an exercise program in these patients. Hence, again, while evaluating the patients, you have to remember a few things. The heart rate at rest in these patients will often be a little higher, whereas the response during exercise will be less. Similarly, the blood pressure at rest is often higher, whereas the response during peak exercise is slightly diminished, which is opposite of what you would see in any other patient. Reason being that we are dealing with a denervated heart. For exercise testing, again, in these patients, if at all you would like to test, you use a modified Norton protocol with the surgical team's clearance, or a cycle protocol of low intensity 10 to 15 watts per minute, or 25 to 30 watts per 2 to 3 minutes. Safer is to use a submaximal 6-minute walk test. When it comes to exercise prescription in these patients, you have to specifically remember that these patients would be on immunosuppressive drugs, and it would cause generalized weakness and reduction in muscle strength. Next slide, please. So what is the exercise plan in a heart transplant patient? Again, in these patients, when you apply the FIT principle, you would know that frequency of aerobic exercise in these patients is 3 to 5 days per week, with resistance training being done after they being in 3 to 4 week aerobic program, and you would start with 1 to 2 non-consecutive days per week. Intensity of using the RP, as I mentioned, the heart rate would not be applicable here. So you will use the rate of perceived exertion of 11 to 14 on a 6 to 20 scale. Practically, pushing the patients up to 13 to 14 is a little difficult, and sticking to 11 to 12 or 11 to 13 on the RP scale is also. Resistance training slowly increase upper body activities over several weeks to months. Begin with somewhere around 40% of the 1 RM, increasing to 70% of 1 RM. Lower body exercises, since leg muscles are larger muscles, they can begin at 50% of 1 hour. Time, the duration of aerobic exercise in these patients increase from 15 to 20 minutes. Now, the guidelines mention 15 to 20 minutes, but you can start as low as 5 to 10 minutes and then gradually over a period of time go up to 30 to 60 minutes as per patient's comfort level. And again, in these patients, you would do 10 to 30 seconds of static stretching with 2 to 4 repetitions of each exercise. Target large body muscles, especially the upper body, the trapezius, the pectorals. Postural correction will be required in these patients. So you would train the back muscles. Type of exercise: treadmill, free walking, stationary cycle on a recumbent bike preferably, or a dual action stationary bike can be initiated. Dumbbells can be done. You can start with TheraBands, weighing machine, weight using a multi-gym is also okay as long as the weight is customized to the patient's tolerance level. Next slide, please. Case studies, my favorite part of the presentation today. Next slide. So the first case study is a 64-year-old female who came to our emergency department, and she's a known case of chronic kidney disease, stage 4. Diabetic, hypertensive, came with complaints of giddiness and palpitation along with raised blood pressure. And she gave a history of new onset dyspnea, NYHA class 2 towards 3. And on evaluation, her ECG showed this. Okay. This is classically your ventricular tachycardia. Once our emergency department saw her, they cardioverted her. Next slide. She reverted back to normal sinus rhythm. They also, she also had an inferior wall MI and primary angioplasty, PCI to mid RCA, right coronary artery was performed for further management. When she went to the ICU, since she was a CKD patient, they saw that she was having rising creatinine level. There were basal crepes. She was getting VTAC recurrently, which was scar ventricular tachycardia. A 2D echo showed EF of 30 to 35%. So the dilemma here was, even after the complete revascularization of done, patient was still getting recurrent runs of VTAC. Then what do you do? Next slide. So she underwent the automated implantable cardioverter defibrillator implantation, which is basically the device that you see in the figure there. And this device would give a small electrical shock to the heart muscle if the rhythm changes to ventricular tachycardia and get it back to sinus rhythm, normal sinus rhythm. That's what the cardioverter defibrillator device is all about. It is called a AICD device. And then the patient was referred for cardiac rehab program on OPD basis after a month. And next slide, please. So today, as of today, so this was an year back. As of today, she exercises 2 to 3 days a week at a moderate intensity of 40 to 45 minutes. She does lightweight training 2 to 3 days a week, with her exercising heart rate being in the range 90 to 95. She requires strict weight monitoring even today, because even over the course of past 1 year, there have been incidences in which there was, because she is a CKD patient, there have been incidences where there was slight fluid again, and therefore her diuretics had to be altered as per that, and check on her creatine. She requires lot of reassurance even today. However, if you see her ECG, it is as good as anyone else's ECG. Okay. And there is no trace of any VPC or any other things that could indicate arrhythmia in her. Dr. Chandramohan, I think I had made some changes in my PPT. Can I share mine? You can stop your
Yes,
screen
ma'am.
share. I think by now the network is a little settled.
Yes, ma'am.
Uh, is the screen visible now?
Yes, ma'am.
So yeah, I had added this. I mentioned that this patient had was NYHA class 2 to 3. So NYHA is New York Heart Association functional classification. Class 1 is these patients have no limitation of physical activity. Class 2 is mild or slight limitation in physical activity. Class 3 would be moderate or limitation of physical activity. And class 4 is a severe class in which patient is unable to carry out any physical activity without discomfort. Here, typically the symptoms that we see is breathlessness. So no breathlessness, slight breathlessness, moderate and breathlessness, and severe breathlessness that I cannot do any activity at all is what it means. And this came with classification of 3 NYHA class, on NYHA class, that is new onset, sudden onset of breathlessness that she had. Case study 2. This is a more recent case because patient has not yet completed the program and is really doing well. I think he's due to complete next week. So it was a male patient, 46-year-old, hypertensive, came to the emergency department with complaints of chest pain radiating to back and shoulder on and off since a week, aggravated since few hours. On evaluation, his ECG showed he had suffered anterior wall MI with EF about 45% with regional wall motion abnormalities of the entire anterior segment of the heart. Patient underwent PCI to the left anterior descending, which supplies the anterior aspect of the heart. And when patient joined rehab around 15 days after he was discharged, during the history, we realized he's a martial arts teacher and he was wanting to get back to his routine. The history that we take here is quite detailed. It is not limited to just the exercise assessment part of it or just the CVS cardiovascular system assessment. We also screen patients for depression using a mental health questionnaire called PHQ-9. I think I've been using it since 2016. It is a there are 9 questions on it. And if you score more than 6, it indicates mild depression. So there is a set scoring system. Anything above 6 would indicate depression with varying severity levels. His score was 12, indicating yes, borderline depression, and the patient is just coming out of certain episodes of grief as well. To top it all, he had this heart attack from nowhere, and therefore you can imagine the kind of anxiety and stress that the patient came to us with. He was very anxious despite reassurance from cardiologists that yes, he was fully revascularized, he can get back to normal life. He was still low on confidence level. Even when he joined rehab, objectively, when we saw his effort tolerance, his 6-minute walk distance was 400 meters, which indicates good effort tolerance. So in these patients, what do you do? A patient is a very fully revascularized young patient, and you know that there is nothing wrong in him. Clinically, he's fine, hemodynamically stable. So in these patients, what more can you do in your exercise regimen? Basically, from an exercise standpoint, do nothing different. Follow the FITT guidelines for post-plasty, post-PAMI patients. Continue to offer counseling to these patients. Be there, offer a listening ear, refer to mental health professional for assistance. Speak to the patient that, yes, we have measured your score. You probably require a mental health counselor, and keep encouraging the patient as and when he achieves clinical milestones. Because then one fine day you will receive a photograph like this on your WhatsApp, that, hey, I'm back to my usual routine, thank you very much. And this is the person in black is the patient who has got back to being the martial art teacher that he is. So I have some ECGs here for that I was able to get from some of our old patients, and uh, typically the ECGs that we see while the patient is exercising. Little bit about the department: we have a telemetry setup, and the patient comes for a OPD based program for about 1 to 3 months, and then the patient continues. We follow cardiac rehab in phases. Phase 1 is what is done inpatient. After the patient is discharged, patient comes to us on phase 2 basis, and that is when we start with the monitored supervised exercise program. So this particular patient was diabetic, and during the course, so this, as you can see, this is a very old ECG from 2016. During the course of exercise, we saw that suddenly his heart rate was kind of going up in phases. If you see here, the RR interval is different. So yes, the patient was having some kind of atrial tachycardia, but the patient also came saying he is having giddiness. After some few seconds, the heart rate increased, and though patient was sitting, you could make out that the ECG was showing a heart rate of 150 to 160. It was not coming down with coughing, or not coming down with just breathing, and patient had to be given antiarrhythmic drug like Codron in the ICU to revert the rhythm. Though it was a fairly harmless rhythm, it was a onset of atrial fibrillation, but it was caught well in time because patient was on continuous ECG monitoring at the time of exercise. This patient, as you can see, this is his ECG, which was taken at rest. And even at rest, his heart rate was going to 44, 45. I do not recollect right now if the patient was having any symptoms, but this was informed to the cardiologist, and we got his Prolomet, that is the beta blocker drug, that the patient was, we reduced the dose of the patient. So coordination with the cardiologist, with the treating physician, is very important. And I think in cardiac patients, when you have an ECG monitored setup, it helps you be more objective when you speak to the treating physician and cardiologist. And they also, over a period of time, they also develop that confidence in you. Yes, you see the well, and coordinate with them for any clinical updates about the patient. This is a patient preserved ejection, HFpEF, preserved ejection fraction. And as you can see, what he's having is wide complex QRSs and some T wave inversions that we can see. The best thing is his ECG is like that. Even if you increase the exercise intensity, you can see that the T waves are not dipping down more, STs are not coming down. So yes, the patient is able to exercise fairly well, but at the same time, monitoring is important. But if you see him for the first time and you see this picture, you probably would not start the exercise at all because he is having such deep T waves at rest. This is a classic ECG of a heart failure patient. You can expect, so in heart failure, because there is accumulation of blood, there is the left heart has to work harder, left side of the heart has to work hard. The heart muscle is thickened and the left ventricle is dilated. Because it is dilated, the electrical tracts are stretched, and hence you will see this kind of ECG picture in heart failure patients, especially those 25 to 30% EF, because the electrical activity of the heart is disturbed. What I have here is a set of bigemini or a couplet, as you can say, in which two ventricular complexes have come after one another. And idea of the ECG monitoring in this is to monitor if these are increasing in frequency, rate, if the patient is having symptoms at the same time, if these are new onset changes that you can see, new onset VPCs, if they were just few in nature earlier and now you are seeing a run of VPCs, patient is may or may not be having symptoms, but you need to monitor these very closely in heart failure patients. So tips for heart failure patients. I think we do have some patients also who are attending today's program. Also, these tips can be given to your heart failure patients when you see them in OPD. The very first thing, as I mentioned, these patients are tired, easily fatigued. So some of these tips are to help them conserve their energy, which is to plan. So they are given tips such as to plan and organize your work. Why? Then it will reduce the trips to reach or delegate work where required, combine motions and activities, perform simplified motions or activities, schedule rest. Rest is very important for these patients. So balance periods of rest and work. Rest before the fatigue starts. Frequent short rests are beneficial. This is something I have also mentioned in the exercise program that you prescribe for these patients. You have to give adequate pacing to these patients, and that is what it means by balancing periods of rest and work or rest and exercise. Pace yourself. Moderate pace is better than rushing through activities. Reduce the sudden or prolonged strain and alternate sitting, standing. Do not stand for a long time. Do not sit for a long time. Prioritize, decide what activities are important to you, what can be done by somebody else. Practice body mechanics when sitting is a well supporting chair. Adjust work heights so you work without bending over. Bend at knees and hips, not at back. These are also general ergonomics. Carry several smaller loads. If you need to carry objects, you want to lift a bag. Instead of carrying one big bag, you can carry one or two small bags. That would help. Limit the isometric work. Breathe evenly. Do not hold your breath. Do not attempt to perform Valsalva maneuver. Identify effects of the environment. Avoid extremes of environment, of temperature. Eliminate smoke. Avoid long hot showers or bath. Hot shower will typically increase your heart rate, and there are chances patient may go in some kind of vasovagal syncope or may faint, and that is why avoid extremely hot showers and reduce the stress by learning relaxation techniques, meditation. I like to add to this, practice gratitude, that helps. Physical exercise, enroll in a cardiac rehab program. So at least you will be in a supervised exercise regimen. anticipate fatigue, know what gives you tiredness, and plan ahead to reduce that stress. Living with heart failure is difficult, and not just the patient, but it also affects the patient family. And it is difficult to learning to live with heart failure is something that we can help the patients do with our knowledge of physical health. And that is my whole point of today's presentation, to so that at least you have some idea of how to help a patient who is having heart failure, and helping them to live with it. Okay. With that, I would like to end today's presentation. I can be contacted on the below email address, and best wishes to everybody. Are there any questions?
Ma'am, I am posting the Zoom link in the group. So those who are having doubts, they can write the doubts in the YouTube comment section, or can join the Zoom link to directly talk to our resource person, Dr. Greeshma. Just hold on, ma'am, for a few seconds.
Yeah, sure.
Dear participants, I am posting the Zoom link now. You are requested to join here. You can join and talk with our resource person if you have any queries. Also, you can write in the YouTube comment section so that I can read your doubts here. There was few appreciations, ma'am, in YouTube. So good session, ma'am.
I can see some people are joining in.
Yes, ma'am. Those who are having any doubts in Zoom Meet, please ask our resource person and make the session interactive. Ma'am, there is a question in YouTube by Suman Chaudhary. How to deal with pacemaker patient?
How to deal with?
Pacemaker patients.
So typically, that's a very good question. I covered AICD, I didn't cover pacemaker. Pacemaker patients, when you, I will answer this question in two parts. First part would be when you see the pacemaker patient right after the intervention is done. That is as an inpatient. That is when you give them advice of left shoulder immobilization. By that I mean patient should not put any stress on the side where the pacemaker is put as a left shoulder. Usually, we tell them not to lift the shoulders above 90 degrees, especially with weights. Elbow movement, however, is permissible. Wrist movement is permissible. Right after the exercise program on OPD basis will be started after their next follow-up with the cardiologist. This will differ from cardiologist to this protocol differs from cardiologist to cardiologist. And typically the patient has to be made conscious of the left shoulder, because sometimes unconsciously we try to put our weight on that side while getting up, etc. Exercise fit principle wise, it would be the same 3 to 5 days in the week. Beginning with 15 to 20 minutes, gradually going up to 40 to 60 minutes. The first month, however, you would go very slow in these patients. Driving is restricted for 4 weeks after the pacemaker and even AICD implantation because of the movement that occurs at the shoulder when you hold the steering wheel.
And the next question is from Deepali. How can we differentiate cardiac and pulmonary dyspnea?
That's a very good question. Cardiac and pulmonary dyspnea, I have one answer for you, one word for you, which I didn't touch today because it's a long topic in itself. Cardiopulmonary exercise test, CPET. Direct gas measurement, you would know oxygen, then you analyze the CPET report, would be able to diagnose whether the dyspnea is cardiac in origin or pulmonary in origin, because many a times the symptoms are same: basal crepitations, increasing fatigability, etc. It's a very good question though. Cardiopulmonary exercise testing, CPET.
Hello, ma'am.
Yes, ma'am.
Hello, ma'am. Are you audible?
Yes.
Yes, you are audible. You can speak.
Ma'am, my question is how to differentiate cardiac failure and the chronic, how to differentiate, is it cardiac failure and the chronic kidney disease? Because ankle swelling is chronic kidney disease also is remaining. So how can we differentiate, is it the kidney disease or the heart failure?
So this is what I believe what we call is a cardiorenal syndrome. There would be at the top of my mind, there would be certain tests such as creatinine would be there. There would be a battery of tests that would be done in a heart failure and a CKD patient. CKD also has its own stages, as you would know. And details of these tests are beyond the scope of today's presentation, but yes, there are different tests that can be done to differentiate between this. It would be typically done by the either cardiologist or the nephrologist.
Okay, ma'am.
Ma'am, the next question is from Muthulakshmi. Will relaxation technique of breathing help heart failure patient?
Yes.
Yes, you have discussed it in the tips also.
Smell a rose, blow a flower. Smell a rose, blow a candle.
Yes, ma'am. There is another one more question from Bapaditya. Ma'am, what about the patients who have both heart condition and peripheral vascular disease?
Peripheral vascular disease patients would also have symptoms such as pain during, say, for example, somebody with a lower leg lower limb vascular disease also have pain during walking. So in these patients, ischemic conditioning can be done. Encourage them to walk through the pain. You will have to monitor their symptoms. Everything would be done under their symptomatic level initially. And depending on what the patient reacts, then you plan the exercise program accordingly. What are the patient responses? Then you plan the patient exercise program accordingly. If a patient only comes to you with a peripheral vascular disease, then ischemic conditioning works. Walking through the pain works. Over a period of time, you would know, or you can see the patient himself will tell you, ma'am, the pain used to come every minute or every.
Donna ma'am, can you please check Greeshma madam is there?
I think ma'am just got disconnected.
Yes,
But we are full in Zoom 100. Yeah, ma'am rejoined.
Yeah, madam is there, yes.
I'm sorry, I missed the question. And
yes, ma'am. We will move on to the next one, ma'am. You was a little bit disconnected. So the next question is from, how can we help a patient undergone heart valve replacement surgery?
How can we help the patient undergo heart valve replace surgery? Is that what the question is?
Yes, ma'am.
Or how do you help a patient after a heart valve replacement?
Yes, that is the meaning actually. After undergone?
After a heart valve replacement. So, heart valve surgery is just like any open heart surgeries. You will have to, assuming it is done in the traditional way, open heart surgery, and not tower that is done via your that is done in cath lab. You will have to take adequate sternal healing precautions. So in these patients, 4 to 6 weeks post suture removal, 4 to 6 weeks post surgery, you begin with the exercise plan for them. Avoid any activities that can disturb the sternal healing. There are certain specific dietary recommendations for heart valve patients, but from an exercise standpoint, treat them just the way you would see a coronary CABG patients, and take care of the sternum. Encourage breathing exercises, chest expansion exercise, thoracic expansion exercises. Explain the patient do's and don'ts. Patient education in these patients is very important. When to use the sternal belt, when to remove the sternal belt, whether or not they can climb stairs. All these things have to be addressed in the patient education.
Yes, ma'am. The next question is, how can kidney disease affect the heart and lungs?
Cardiorenal syndrome. Back again, the same thing. Heart, pooling of blood, volume overload, pressure overload, that is a whole thing altogether.
Yes, ma'am. The next question is, how long we restrict shoulder ranges in pacemaker patients?
So shoulder immobilization. So pacemaker patient would have a small suturing done. Okay. Typically, the sutures would be removed after 10-12 days. I tell the patients to not put any weight and not restrict for at least 1 month from the pacemaker. Reason being that patients sometimes are a little enthusiastic, and that's why I put these restrictions. You don't want the leads moving, the lead movement happening. That's
Yes, ma'am. The next question is from Amulya. Is missed beats, heartbeats, common in kids below 10 years old?
Missed beats common in kids below 10 years old. Honestly speaking, I do not know the answer for this. I can check up and let you know.
Yes, ma'am. Thanks for that. And the next question is, how to plan an exercise program to a patient with a LVAD, LVAD.
LVAD. So I've covered LVAD in my presentation, fit principle and special considerations for LVAD patients. As I mentioned, LVAD is an artificial heart device, and in these patients, pacing is important, starting with 3 to 5 days in a week, RP of 11 to 12. After they are in the 4-week exercise program, then you begin with the resistance training at low intensity again, 1 or 2 days in a week only.
And one more, that what will be the exercise protocol for CABG patients? I think that is a very extensive thing. Yes, ma'am.
CABG, so typically, let me again answer this question in 2 parts. Phase 1 of post-op patient is when the patient is just operated and drains are out, where you are given the green signal to start off with the exercises when the patient is in ICU. So you start off with the breathing exercises, deep breathing exercises, if required, chest expansion exercises, and little low intensity functional activities such as sit to stand, walking around, based on the patient response. Okay, patient typically would be in the ICU, and the inpatient stay would be at least 4 to 6 days in the hospital. So that would be your phase 1 of cardiac rehab that is done for a CABG patient. To also educate the patient and family members about what are the specific do's and don'ts that have to be done at home, because these patients, CABG is a major cardiac surgery. So they would have a lot of questions for you and a lot of anxiety related to how to get the patient home and what to do after the patient is home. How to use the chest belt, how to wear the chest belt, when to use the chest belt, when to remove the chest belt. These instructions also have to be given to the patient. Typically after suture removal, we start the cardiac rehab in 2 days or so. Suture removal happens if the sutures have to be removed. Then the sutures removal happens after 15 days of cardiac surgery. Sometimes in diabetics, this is delayed, but eventually, obviously, the sutures will be removed and then you can start the exercise plan after 2 days. Key thing in any open heart surgery is the sternum. So sternal healing is very important, and avoid doing any activity that would cause a stress across the sternum, which means say holding weights and moving, doing shoulder abduction, for example. Begin with low intensity exercise, stationary cycling, treadmill, depending on patient age and patient's physical stamina. 6-minute walk distance is done prior to 6-minute walk test is done prior to starting with the exercise program on OPD basis after the patient is discharged. And phase 2 of cardiac rehab would last for somewhere around 1 month. Phase 3, 1 to 3 months will be phase 2. Phase 3 will be 3 to 6 months, and phase 4 will be typically maintenance phase. And
Yes.
increase the exercise intensity once you can see that the sternal sutures are healing well, etc. So that would be somewhere phase 3 of cardiac.
Yes, ma'am. The
Phase
next
2 will be
question
low
is,
intensity, intensively supervised phase.
yeah, the next question is, a person after open heart surgery and after 3 months rest period, should they take care about the rest period on work and lifting weights?
Can you repeat the question for me, please?
A person after open heart surgery and after 3 months rest period, should they take care about the rest period on work and lifting weights?
So when you are in car, there is no rest period for open heart surgery, not anymore, not since the past 10-15 years. After open heart surgery, we are making you walk in the ICU in the floor itself so that your return to work is faster, getting back to normalcy is easier. Low intensity activities, walking done at home also in certain frequency, certain time throughout the day is recommended. Spirometer, incentive spirometer is given, that needs to be done. Lifting weights, we can start weightlifting if the patient has been in a supervised exercise program for at least 3 to 4 weeks, and then we can easily start weightlifting resistance training in these patients.
Okay, ma'am. The next question is left shoulder pain is always related to cardiac problems?
Left shoulder pain, typical chest pain, specific chest pain is left shoulder pain radiating to left arm, back, jaw pain. These are what we call as typical angina symptoms. But having said that, to answer your question, no. Left shoulder pain can be, say, frozen shoulder for that matter. Okay. And you have to assess the mobility of the patient. Chest pain for that matter can also not be cardiac pain, it could be acidity. And the other way around, sometimes the patient is having cardiac issues and it is being diagnosed as acidity. So that is where your ECG comes into picture, enzymes such as tropi reports are seen. So it is not just the symptoms that the patient presents to you with, but also your clinical evaluation of reports and reports that you see. That helps you in the diagnosis.
Yes, ma'am. The next question is, what are the contraindications for exercise in heart failure? And what are the home programs for heart failure patients in initial phases of cardio rehab?
Contraindications for heart failure are many. I will share the list with you separately. Okay. Absolute contraindications and relative contraindication. To start off with, let's say patient comes with resting blood pressure of 180 by 110, I will not start the exercise program. Just an example. Regarding the home exercise program, low intensity activities based on what stage the patient is in, what stage of heart failure, what is the patient's initial stamina. We can do a home exercise program. In heart failure patient, a home exercise program may have certain risks, especially in low EF of 25 to 30%. So I recommend that you have at least seen the patient for a month with you. You know the patient's ECG, you know the patient's response, and then go to a home exercise plan. Having said that, safe range for these patients would be to do lower intensity exercises, walking, some chair exercises, breathing, relaxation. All these can be done as a part of a home exercise program. Stretching, postural correction, all these can be done as a part of a home exercise plan. But it is always better before you prescribe a home exercise plan that you have at least seen the patient once, seen the patient's ECG during exercise, done a 6-minute walk test, and then you prescribe the exercise.
Yes, ma'am. Does exercise prescription increases LVEF?
Exercise does help in LVEF. Having said that, when you have a heart attack and the heart muscle is damaged, patient comes in time, fully revascularized over a period of time, the EF goes up because there is blood supply that is restored, and heart muscle itself goes into a remodeling kind of scenario that takes some time. Regular exercise does increase EF, but it's not something that will go up in a month or 2 months or 3 months. Again, if there is a scar tissue, then it is a little difficult for that EF to go up. So more or less, yes, exercise helps. If so, EF is at the end of the day, a number of your, which is checked by visual estimation. If the patient's quality of life is better than what he came with, then I recommend that you don't, we tell the patient, don't go by the EF. You are able to do things, okay? And such reassurance is required, because then the patient goes into thinks that, okay, if I exercise more, my EF will go more. That's not the case.
Yes, ma'am. The next question is, why is 6-minute walk test important, and what is the abnormal responses there are? They want to know that the result of that, how it is useful.
So in heart failure patients, 6-minute walk distance, one, it is easy to do, so you can easily perform the 6-minute walk test. If the patient is able to walk 300 meters, then it is of prognostic importance, because it has been shown that these patients have better survival outcomes if you have reached a minimum. These are research studies that have been done. So then they have come to this number. And those who walk less than 300 meters, they have poorer prognostic outcomes. Responses that are not as per usual responses. I would say if the patient has walked 6 minutes and the peak, the heart rate has not gone up, okay, or the oxygen levels are going down, saturation is going down, blood pressure has not adequately increased, or blood pressure has shot up so much that it is not commensurate with the level of exercise, level of space of walking that the patient. Next.
Ma'am, is Greeshma ma'am there?
Yes, ma'am is there.
Yes.
You are not audible to you, that's why. The next question is, how can we handle a patient with persistent arterial fibrillation with preserved ejection fraction in terms of exercise prescription?
That's a very good question. I'm assuming you are referring to chronic atrial fibrillation. Uh, yes, you can plan an exercise program in these patients. The protocol remains the same. These patients will require ECG monitoring, and because you want to see because the patient already has a chronic AF. If the patient is on chronic AF, most likely the patient is also on medicines that are keeping it in that controlled atrial fibrillation. It will not be uncontrolled atrial fibrillation. So you can safely do the exercise plan in them.
Yes, ma'am. The next question is, what are the home programs for the patient who have gone through stent replacement? The
Uh,
replacement.
so I think the patient means angioplasty or stent placement.
Yes, yes.
Yes. So there, if a patient has undergone primary and PAMI after a heart, if a patient has suffered a heart attack and the patient is revascularized and the stent is put, then the exercise program is started typically after 15 days. If the patient has gone for a regular health checkup, the stress test has come positive, and you realize that, oh, patient then undergoes angiography and angioplasty is done, and his EF then is 55 or percent or normal, and patient is fully revascularized because stent is put. Patient can start the program in 3 to 4 days after the stent placement. And in such patients, the intensity of exercise might be a little more than in comparison to somebody who has undergone stent after a heart attack.
Yes, ma'am.
Aerobic
In case
exercise.
that,
I'm sorry.
yes, ma'am. Yes, ma'am. Please continue.
Exercise duration would be 30 to 40 minutes and gradually going up to 60 minutes. Weight training can be done 2 to 3 days of the week. That should not be a problem in either of the patients. Just the intensity in both will differ. Whether you have the stent is put after a heart attack or whether it was an elective angioplasty or which was detected because patient went for a health checkup and angiography was done. EF is normal. Angiography was done which detected blockages and patient's heart muscle is not damaged. It is patient was.
Yes, ma'am. The next question is, in case studies, I can see many investigation as baseline assessment, example ECG. So my question is, does you change your exercise prescription based on your electrolyte values, example sodium and potassium?
So the case studies that I discussed, the evaluation was done when the patient that I showed in my presentation. Evaluation was done when the patient came to the emergency department and they run a battery of tests at that point. Having said that, what would change my exercise plan when it comes to a blood test would be, yes, if the patient's electrolytes or say potassium is more than 5.5, 5.6, I will ring the cardiologist and say, do something. Patient sodium is going low, I would still inform the cardiologist and say, this is happening. It could be a side effect of a medicine that the patient is taking, especially those patients who are CKD patients. Uh, uh, if the patient's blood pressure is lower, so it will require certain changes in the medicine again. So a lot of the cardiac rehab process that happens with coordination with the cardiologist or the treating physician. And for that, yes, you need to have some idea of what are the common cardiac drugs, what are the common side effects. Many a times patient would expect you to know this as well. What are the common changes in ECG? If you would, if say potassium is high, what is the changes in ECG that you would see, etc. So these things are important.
Yes, ma'am. Can we check the cardiovascular fitness by doing Cooper's 12 minutes run test to any patients who have cardiac problems, though we use this test for athletes?
I personally haven't used Cooper's 12-minute thing for any of my patients because, as you rightly said, these are done for athletes. I usually stick to 6-minute walk distance, a 6-minute test, but I believe you can, if you want to, there are maximal exercise testing, other options such as CPET available, cardiopulmonary exercise testing, if the goal of if your goal is to stress the patient to maximal limits. However, CPET to be done in a cardiac patient, there has to be a safe duration after the intervention that is done. For example, you cannot do it immediately in a CABG patient. You will do it, say, 6 months down the line or a year down the line. If it's a heart attack patient, again, you would not do it immediately. You would do at least 3 months down the line. So if the goal of the question is that is maximal exercise testing, is that was expected? Maximal exercise testing in cardiac patient? Is that what was the intention of the question?
Yes, yes, ma'am. Whether he wants to say whether we can do any other exercise testing, or
Yeah.
why don't you try this test, or have anyone tried this test? Is there any information he needs? That's why he posted this question. So the next question is from Rashmita. In case of HFPF, why EF is greater than 50%? What is the mechanism behind it?
Because the heart muscle is not damaged. HFPF would be preserved ejection fraction, which is near normal ejection fraction. It would be more of a diastolic heart failure. I can confirm on that. That is why the it is a preserved ejection fraction, PEF.
Yes, ma'am. So the next question is, do children with heart surgery have different exercise prescription from adults?
Yes, children with heart surgery would have a different exercise prescription in adults because the physiology in kids is different. And handling of kids is different. You cannot tell them, Acha, you sit on the cycle and do cycling. You have to incorporate activities that are playful in nature and at the same time serves the goal of exercise or activity that is done. And that is why exercises in children would be differently done. Sternal healing precautions would be the same. So instead of spirometry, ask them to blow a balloon, for example, something that is playful in nature for them.
Yes, ma'am. The next question is, exercise prescription in patients on ECMO. Exercise prescription in patients on ECMO.
Yes. On ECMO, oh, that's a good thing. Yes, I'm happy to hear this. Exercise prescription on patients on ECMO, first, even the exercises, if and when done after surgical clearance, yes, would be limited to breathing exercise, low intensity, passive, active, assisted exercises because patients will be on the bed. And most importantly, infection control precautions. When you enter the patient's room, infection control precautions have to be taken. You will have to be more conscious about the gloves, about the mask, and about the making sure that you are not introducing infection in the room in any way.
Okay, ma'am. The next question is, can taking antidepressants affect the exercise testing?
Yes, I have seen patients on antidepressants with a higher heart rate. So exercise, I wouldn't comment if it would, other than the fact that the patient would come with a higher resting heart rate and probably require more encouragement during the exercise testing. or would be more tired during the exercise testing. But exercise prescription also, it would be, you will have to go slow because the resting heart rate may be high in these patients. So if there is a higher resting heart rate, say 90, 100, you cannot start off with a moderate intensity exercise plan. You have to start with a mild intensity exercise plan.
The next question is, in my clinical area, I have seen patients who have less EF, ejection fraction, that is less than 40% pre-operative, who have undergone revascularization procedure, but not improved EF post-operatively. What modification is needed in exercises?
It depends how much time post-op are you rechecking the echo of the patient to see the EF. From an exercise standpoint, begin with whatever are the standard guidelines for the patients and use RP as a measure. Begin with the exercise intensity in the range 9 to 11, gradually go up to 11 to 13. Keep your goal as getting effort tolerance of 40 to 60 minutes of regular aerobic exercise done. You should be okay. It may or may not improve the EF because that depends on variety of other factors. How is the myocardium, whether there is scar tissue, etc. But that is what standardly you would do. And rest, hope that the collaterals develop.
Okay, ma'am. The next question is it safe to exercise or mobilize a patient with acute or chronic atrial fibrillation? As I know with clinical expertise, there are complications to develop embolism leading to stroke.
That is true. So acute atrial fibrillation, obviously, we would not prescribe any exercise. We will wait for the rhythm to convert into normal sinus rhythm. As you rightly said, there are chances of thrombus, a clot dislodge, and it could lead to stroke or a pulmonary thromboembolism.
Yes, ma'am. We have two more questions. One is how to differentiate between symptoms cardiac failure and cervical radiculopathy.
Cervical radiculopathy would also be associated with tingling numbness of the arms, radiating in the upper body, and heart failure symptoms. Heart failure, since you mentioned, symptoms would be tiredness, swelling of legs, breathlessness.
Yes, ma'am. The next question is
different symptoms.
The post CABG or valve replacement patient shoulder joint full range of movement. Can we start immediate post-op?
Yes, in fact, shoulder mobility in these patients, active assisted movement, shoulder flexions should be done, because if you don't do it, the patient would go in some kind of chest tightness. So do it slowly, but can be done. What you should avoid in the initial immediate phase is chest shoulder abduction. But that can be also, that is as a part, can be started after few days, because these are shoulder rotations are a part of the home exercise physiotherapy plan that is given to patients. If the patient doesn't do it, then on the contrary, patient will end up with either a stiff shoulder or a tight chest.
Yes, ma'am. Final question.
Yeah.
Please continue, ma'am, if you are answering.
The sternum is very well held together by the surgeon, and your shoulder movement will not affect it.
Yes, ma'am. Ma'am, is it safe to provide breathing exercises with patient having hypotension, that is 90/50 mmHg?
So there are some patients who live on 90/60 blood pressure, heart failure patients. There is You can safely do deep breathing exercises in them. It will induce more relaxation in them. So if the patient is symptomatic with a 90/50 blood pressure, even then you can still give deep breathing exercise, but not have them exercise until the cause of this hypotension is determined. Because patient could have symptoms, giddiness, weakness, etc. Deep breathing exercise is fine. Breathe in through nose, breathe out through mouth.
Yes, ma'am.
Even thoracic expansion exercises are fine.
Yes, ma'am. Thank you, ma'am. This is a very wonderful session, and there are a lot of appreciations. And also, we will send a feedback link, and we will get back to you. And I thank all the participants. This was really wonderful, and it was more than 1,500 registrations. I'm so happy about it. And if you have any other questions, feel free to contact us, and we will get back to you. And I thank Duna ma'am once again for the Zoom link to the YouTube. And I thank all the participants and resource person once again. Good night, all of you. Thank you.
Thank you so much, ma'am. Thank you, sir. Good night. I'm closing
Thank
the
you,
session.
everyone. Thank you, Dr. Chandra Mohan. You have been a fantastic host throughout, and Duna ma'am as well. Good
Thank you,
night
ma'am.
to
Thank
both
you
of
so
you,
much, ma'am.
and take care.
Take care, ma'am.